All right, so I see it just became 10:05, and I think the attendee number has started to plateau. So we'll go ahead and get started. So thank you everyone for joining this webinar on the role of MRD-based recurrence detection in early stage lung and breast cancer. Um, I'm David Kurtz. I'm the Chief Medical Officer and Head of Research at Foresight Diagnostics, and it's my distinct pleasure to be on this webinar with Max Diehn from Stanford University, as well as Luc Cabel from Memorial Sloan Kettering. This is a brief reminder of how these webinars work. We will go through a few talks. We'll each do a session about 10 to 15 minutes. For questions that you have interest, please use the Q&A button as part of the Zoom controls there, and we will get to as many questions as we can after everyone has gone through their data. With that, I'll give a little bit of an overview as to the state of the art in MRD and what we talk about when we think about MRD at Foresight. Just a brief introduction. When we talk about minimal residual disease or MRD, this is really talking about looking for microscopic tumor burden that remains after curative intent treatment in patients who don't have any other clinical evidence of disease. So detection of MRD shortly after completion of local therapy, such as surgery or curative intent radiation therapy, could potentially allow us to identify patients who are likely to recur and allow personalization of adjuvant therapy decisions. Now, there's been, in the last 10 years, really explosion of technologies to look for MRD. In the blood cancer space, these include flow cytometry and PCR. In solid tumors, this is really focused on next generation sequencing of circulating tumor DNA, or ctDNA, as the dominant method by which we try to track MRD for solid tumors. But just as a little bit of a contrast between these emerging ctDNA-based MRD tools and traditional diagnostics that we've used to track patients in the clinic, the two real comparators that we have are imaging and existing blood tests. So for imaging, like PET-CT scans or CT imaging, these have a hard time detecting minimal residual disease. Very small pockets of micrometastatic disease or small residual disease burden don't show up very well on PET-CT scans. Furthermore, these images lack specificity for cancer. Inflammation and infection, other things can show up on a CT scan or a PET-CT scan that are not cancer. These, of course, also lead to patients having radiation exposure. Prior generations of blood tests have been attempted to look for MRD. These mostly include protein-based biomarkers. These are traditional biomarkers that we think of, things like CA-15-3 for breast cancer, CEA in colorectal cancer, and CA-125 in ovarian cancer, have been used to track patients' disease over time. However, these also suffer from poor specificity and are not applicable to many cancer types and are not applicable to all patients. So really, we need better tools to move this MRD field forward. So this is where ctDNA MRD detection really comes in and offers a lot of excitement and possibility to move the field forward. ctDNA MRD is potentially more sensitive and certainly more specific when we're talking about tumor-informed MRD, with limits of detection ranging from a few parts per thousand down to below 1 part per million using the Foresight CLARITY assay. ctDNA MRD is quantitative and dynamic and correlates with tumor burden over time. It's non-invasive, which is performed from a simple blood test, and it can provide genotypic insights depending on the panel and the assay that's being used to inform on clonal evolution and driver mutations for a given patient's tumor. Before we get into some of the data in lung cancer and breast cancer, I do want to touch briefly on differences when we think about different technologies for ctDNA MRD detection, putting these into two broad categories. We can think about ctDNA MRD in these two categories of tumor naive versus tumor informed. And the major difference between these types of technologies are whether or not we know what the patient-specific tumor looks like prior to going and trying to identify MRD in the patient's blood plasma. So in the case of a tumor-naive assay, this really is performed from a blood draw with no tumor tissue. cfDNA is then extracted. A cancer-specific or tissue-specific marker is then used to detect disease in that patient's blood plasma. Now, importantly, no personalized set of reporters are first identified in that patient's tissue sample, which of course is very attractive. You don't need the patient's tissue sample. However, this also potentially suffers from problems with specificity. There are many different methods to go after this type of tumor-naive methodology. These includes looking for recurrent driver mutations, methylation, or fragmentomics. But these methods tend to suffer from lower sensitivity compared to the tumor-informed assays. They also have problems with specificity because they don't rely on that patient-specific set of mutations. And there's a lot of excitement in terms of applications for these tumor-naive methods, including mutational genotyping, as well as potentially cancer screening. But given the lower sensitivity of these assays, true MRD detection has been challenging with these approaches. Now, in contrast, tumor-informed methodologies depend on first having that tissue biopsy, a source of patient-specific tumor material, where we can then identify a set of personalized markers to track over time and move forward for a given patient's cancer. By using this personalized set of mutations that are discovered in the patient's tissue sample, we can achieve better sensitivity and specificity, ranging from parts per 10,000 in the first generation assays down to parts per million or even below in second generation ctDNA-based assays. And this has the most data and the most potential in the MRD applications. Now, early data looking at ctDNA MRD from first generation assays really led to this excitement in the field in lung cancer and breast cancer. So shown here are two studies from 2017 using different methodologies to detect ctDNA after curative intent treatment in limited stage lung cancer. And you can see that both of these plots are highly stratified for patients that ever have detectable ctDNA, shown on the bottom curve, the red or the green curve, or patients that never have detectable ctDNA in the top curve. And these really excited the field and started to move the field forward. But there's important limitations here. And that important limitation is that these are not landmark analyses. These really are looking at longitudinal tracking of ctDNA over time after a patient had their curative intent treatment. And while that is great for demonstrating the possibilities of an assay, it's not really how we think about treating patients in the clinic. Treatment decisions are made at landmark time points after curative intent surgery or after curative intent radiation. Does the patient have residual disease? And should we add adjuvant treatment to that patient at that time? And this is where the first generation assays have more challenges. In fact, when we look at first generation ctDNA MRD assays, in a landmark analysis, we can see that there's a very high rate of false negativity. So this is looking at early stage lung cancer across 3 different studies using 3 different assays. And broadly speaking, the sensitivity for residual disease at that landmark time point for patients who will ultimately go on and have disease recurrence is about 1/3. Each different study here uses a different definition of what a landmark is, but about between 35 to 40% of patients will have ctDNA detectable, which means that over half of patients, and almost 2/3 of patients who ultimately recur, will initially have a negative ctDNA result using these first generation assays. And this is where we think that there is room for improvement, and second generation assays offer a lot of potential to improve on these results. So because of this, the clinical adoption, both in terms of coverage and usage, both in the clinic and in guidelines, in early stage lung cancer and breast cancer has been somewhat mixed. Currently in NCCN guidelines, there is no clinical recommendation for ctDNA-based monitoring. There are recommendations on liquid biopsy for non-invasive tumor genotyping in advanced disease, but no recommendations on monitoring. While Medicare coverage does exist in breast cancer, no coverage determination has been granted in early stage lung cancer. So really, this begs the question, and we hear this from clinicians quite frequently: what do we do with a positive result? The reason that this is not taking off in the clinic is we don't really know how to use these positive results as we move forward into the clinic. And so more prospective MRD-based assays are really needed to determine this utilization. So again, focusing on where these first generation assays can be improved upon, as we at Foresight move forward with the Foresight CLARITY assay and a second generation ctDNA MRD assay, what we see is that even in pre-treatment samples, so in patients that have not in the MRD setting, just have measurable disease on imaging in pre-treatment setting, a large fraction of patients have ctDNA MRD levels that are below the limits of detection for first generation assays. Shown on the left, we see early stage lung cancer cases where over half of patients have levels below 1 part per 10,000. Similarly, in early stage breast cancer cases on the right, over a third of cases have levels before any therapy below 1 part per 10,000. So if these patients have ctDNA levels this low, even prior to receiving any treatment, more sensitivity is clearly needed to detect MRD after surgery and after treatment. So as we think about how we can increase sensitivity for ctDNA MRD assays, really there are two main levers and knobs that we can turn to try to improve sensitivity. It really comes down to how many mutations do you track and what's the background error profile of your assay. So by increasing the number of mutations that are being tracked, it gives us more opportunities to detect a ctDNA molecule. Likewise, we need to have a lower background error profile to utilize all of these additional mutations and to actually leverage those mutations for detecting down to parts per million or below. So this brings us to the Foresight CLARITY assay and phase-seq. So Foresight CLARITY, which is the MRD offering from Foresight, is powered by phased variant technology, or phase-seq, to lower the background error profile for MRD detection. So for those of you who are unfamiliar with this technology, phased variants are 2 or more single nucleotide variants that occur on the same cell-free DNA molecule. These phased variants afford a much, much lower background error profile because to detect a single cell-free DNA molecule and identify it as tumor-derived, you need to see concordant observation of 2 or more mutations on that one individual molecule. This gives us a much better signal-to-noise profile to track MRD levels down to 1 part per million or below. So if you think about these phased variants, they actually are quite common across a number of different cancer types. We built Foresight CLARITY initially for lymphomas due to the biology of B-cell lymphomas. But actually, when you look genome-wide across many, many different cancer types, phased variants are quite recurrent in the cancer genome. They just don't occur in stereotyped regions of the genome in all cancer types. So because of that, our main goal, and as we built Foresight CLARITY, we perform the following. Our MRD offering starts from tumor DNA isolated from tumor tissue, along with a paired source of normal DNA. We perform whole genome sequencing and identify up to 5,000 targets, prioritizing phased variants, as well as other low error profile tumor-specific alterations, such as SNVs and other mutation types. We then design a patient-specific assay targeting up to 5,000 of these variants that we can then take forward for an individual patient's tumor fingerprint. Using this panel, we can then go forward and isolate cell-free DNA from a given patient, use that custom panel, and track MRD using our custom bioanalytic platform down to a limit of detection below 1 part per million, 0.3 parts per million LD95. So Foresight CLARITY, as I mentioned, has an LD95 of 3 parts per 10 million, or 0.3 parts per million. And this was in data presented at the ESMO conference and will also be presented at the San Antonio Breast Cancer Conference later this year, focused on the analytical performance of this assay. Again, up to 5,000 patient-specific loci are used, and we prioritize all of the tumor-specific phased variants. And we then fill out our panel using other low error profile variants to bring that total up to 5,000. So what this affords is up to a 100-fold or more improvement in sensitivity versus first-generation SNV-based assays due to that dramatic lowering of the background error profile using the Foresight CLARITY assay in PhasED. So with that in mind, I will hand it over to our first panelist to talk about some of the clinical data and the performance using PhasED in early-stage lung cancer. So I'll ask Max Diehn. He's a professor and oncologist at Stanford University and one of the co-founders at Foresight to take it from here.
Great. Thank you, David. Thanks for that introduction. All right. So in the next couple of minutes, we'll cover results from use of the ultrasensitive PhasED approach for detection of MRD in early-stage lung cancer. Here are my disclosures. The relevant one is that I'm an academic co-founder of Foresight Diagnostics. Before we get into the data, early on, as we were developing the platform, we did a modeling exercise to ask how sensitive an MRD assay do we need if we want to detect the majority of MRD in early stage lung cancers. I'm a lung cancer oncologist and see lung cancer patients in my clinic every week, particularly early stage lung cancer patients. And so I've been very interested in bringing MRD technologies and assays to lung cancer patients. And as David summarized, the first generation approaches, as exciting as they were, unfortunately just haven't been sensitive enough to really allow us to bring them to the clinic. And so the first thing we did was to perform a modeling exercise where we analyzed data from a published study from the TRACERx consortium, which had used a first generation assay. But in that study, there were 38 early-stage non-small cell lung cancer patients who ultimately developed recurrence, so we knew they had MRD, where they had consecutive post-treatment blood samples drawn that had detectable ctDNA with the first-generation assay. The reason that was helpful is because that allowed us to estimate the growth rate or the rate of increase of ctDNA when patients are not undergoing treatment. And on the left is shown an example of one patient from these 38 that had 6 different blood samples that meet those criteria. And you can see that you see, in effect, exponential growth or increase of the cell-free DNA MRD when patients are not being treated. Now, this was true basically for all the patients in this study. And then so we could fit this personalized exponential growth curves to each of the 38 patients. And then once you have those curves, you can do a couple of interesting things. The first thing we could do is ask, what is the doubling time of ctDNA MRD in early stage lung cancer? And we saw on the distribution on the right, where it's really bimodal, the majority of patients have doubling time of about 50 days. But there's a smaller group that had doubling times about 3 times that long, 150 days. And interestingly, that subgroup was enriched for patients with stage 1 non-small cell lung cancer, suggesting that the patients that we diagnose at stage 1 may be enriched for tumors that are less aggressive and grow slower, which of course makes some sense. Now, the main goal was to then use those models to track back. And now once you have those mathematical models, you can ask how low must the ctDNA MRD concentration have been shortly after surgery in those patients. And when we did that with these models, we found the following results: that if we assumed we would be using a first generation type assay, it has a limit of detection of 1 part per 10,000, 1e-4. The model said we should be able to detect about 40-ish% of the patients who would ultimately develop recurrence. Very similar to the data Dave showed you from the published studies with first generation assays. But then we could ask, well, what if we had an assay that goes to 1 in 100,000 or 1 in a million? And you can see that really you want to be in the range of at least 1 part per million in order to be able to have a chance to detect the majority of minimal residual disease in early stage lung cancer at a landmark time point, so shortly after completing their definitive therapy. And so this set the target spec for what we thought an assay would need to perform at in order to be able to use it successfully in this setting. And so David introduced the phase-seq technology, which David led the development of in our group at Stanford when he was a trainee with us. And that is the basis of the Foresight platform. And one of the, it seems to be jumping by itself.
That was me. Sorry, Max.
Okay, no worries. One of the first experiments we did was to then perform an experiment with collaborators at Memorial Sloan Kettering, Jay Isbell and Bob Lee, where we analyzed a cohort of 46 patients, all early stage non-small cell lung cancer, treated with standard of care. So this was sort of a study of sample cohort of convenience, so collected alongside standard of care. They all had surgery as a definitive local therapy, and some had neoadjuvant treatment, some had adjuvant treatment, some had neither. And the experiment we wanted to do was to compare MRD detection using this ultrasensitive phase-seq approach David introduced versus a first-generation SNV-based approach. And so we did that by running both types of assays, the phase-seq assay and the SNV-based MRD assay, on the same plasma samples from these patients, so we could do a direct head-to-head comparison. The cohort characteristics are shown on the right. Key points are that this is a cohort enriched for low shedding cases. Over 75% were adenocarcinomas, which shed less than non-adenocarcinomas, and almost 2/3 were stage 1, 2, which of course shed less. Now, from a methodologic standpoint, for this experiment, this used a phase-seq assay tracking 2,000 phased variants per tumor. So I highlight that because, as David mentioned, the Foresight CLARITY assay, which is the assay that Foresight is developing for real-time patient testing, actually tracks 5,000 variants, and I'll mention that again at the end. But this was an earlier generation, the first generation, just a pure phase-seq assay tracking 2,000 phased variants per tumor. All right, so then the first thing we looked at on the left was what is the actual limit of detection that was achieved in the samples. And with the phase-seq assay, you can see that the median LOD was right at 1 part per million, this LOD95, whereas on the same blood sample, the LOD95 for the first-gen SNV-based approach was right around 1E-4. Or 84 parts per million, just as we had expected based on the analytic validation experiment we've done with both approaches previously. Now, you do see there's a range, especially even in the phase-seq side, where the majority of samples are at 1 part per million or below, but some have higher LODs, and that was for two reasons. One, the amount of plasma available for some of those samples, and number two, the number of phased variants that were detectable in those tumors. So some patients had less than 2,000. So then on the right is the key result, which is the actual detection of MRD in the post-treatment sample, the landmark samples. And the first two bars show the sensitivity, where with the first generation assay, we were able to detect 28% of patients who ultimately recurred in the first post-treatment plasma sample. Whereas in those same plasma samples, we were able to detect 67% of eventual recurrences with the phase-seq approach. So more than twofold increase in this clinical sensitivity for MRD detection. Importantly, this did not come at the expense of specificity. Specificity was still 100% for the phase-seq assay, actually a little bit lower for the first-gen assay. Next slide. And this translates into the following Kaplan-Meier difference. On the left, you see the result with the first-gen assay, and you get this separation of the curves as we would expect, but the separation of the curve is much better in Kaplan-Meier on the right, and also the same sample using the phase-seq assay. And you can see that because you're detecting more than twice as much of the ultimate recurrences, you get a much bigger difference in the separation of the curves. Next slide. I think it's useful to look at a few vignettes to see how this actually looks in practice. So this is in blue here is the result with the phase-seq assay. In gray is the result on the same samples with the SNV-based assay. This patient had stage 3 non-small cell lung cancer, received neoadjuvant chemotherapy. During neoadjuvant chemotherapy, the first-gen assay became undetectable, but then became detectable again after completion of the chemotherapy, indicating that was a false negative result during chemotherapy. But with the phase-seq assay, you can see you can still detect the ctDNA even during the chemotherapy down to near 1 part per million. The patient then has surgery, and after surgery, the first-gen assay becomes undetectable again, suggesting maybe this patient had been cured. But we can see that with the phase-seq assay, the more sensitive assay, there is indeed still detectable MRD at about 1 part per million. And the patient then went on to receive post-op radiation therapy to the mediastinum, the lymph node region. And that after that repeat measurement with both assays was negative, suggesting that that cleared microscopic residual disease. And this patient's now many months out and doing well. Next slide. Here's another example, a patient with stage 3 lung adenocarcinoma. This patient received neoadjuvant immunotherapy, dual immunotherapy with ipi-nivo. And you can see that didn't really have much of an effect. ctDNA didn't drop with either of the assays. Then the patient has surgery. And after surgery, again, ctDNA becomes undetectable with the first generation method. But with the phase-seq approach, it is still detectable now a little bit above 1 part per 10 million. So very, very low levels of ctDNA. But this is a true positive because the patient unfortunately ultimately developed recurrence with an adrenal metastasis that was biopsy proven and surgically removed. So indicating this additional sensitivity can be quite important clinically in order to really be able to distinguish patients who have very low levels of microscopic disease. Next slide. And then we did, this is a small cohort, of course, so these are exploratory analysis, but we asked, could we see the adjuvant effect with the phase-seq ultrasensitive approach? And this is only looking at the ultrasensitive result. On the left Kaplan-Meier are patients who were negative post-operatively, and in blue are the ones that received adjuvant therapy, and in red are the ones that did not. You can see there's really no difference in outcome. Whereas on the right, patients who were MRD positive post-operatively with phase-seq had certainly better outcomes if they received adjuvant therapy than if they did not. Next slide. And then this is analysis now of the subset of patients who were MRD positive after surgery and received adjuvant therapy, and then asking what were the outcomes, whether or not the MRD is cleared by the adjuvant therapy. And what you can see is that if the adjuvant therapy does not clear the MRD, the patients all recurred, whereas the majority of the patients where adjuvant therapy cleared the phase-seq MRD had long-term disease-free outcomes, suggesting that with these sharper tools, we can actually see the effect of adjuvant, meaning that not only could one envision using ctMRD to select patients for adjuvant therapy, but also to then track the efficacy of adjuvant therapy, for example, as an early surrogate endpoint for reading out efficacy. Next slide. So then in summary, in the absence of treatment, ctMRD increases exponentially if we don't intervene, and those patients are extremely high risk for recurrence, so ideally suited for escalation strategies. Based on modeling, ultrasensitive assays in the at least part per million, ideally below part per million range, will be required to be able to detect the majority of MRD in early stage non-small cell. phase-seq is such an ultrasensitive method that can detect twice as much MRD, or more than twice as much MRD in early stage non-small cell lung cancer. And the Foresight CLARITY assay that David showed is that the evolution of that with an even further improvement in LODs that we're very excited to apply to lung cancer cohorts moving forward. And I'll stop there and turn it over to Luc.
Hello, everybody. So I have no disclosure. So in early breast cancer, we use several factors to predict the risk of recurrence for our patients, including clinical factors, histologic factor, oncotype, for example. And based on this risk assessment, we decide to offer or not neoadjuvant or adjuvant treatment. But we do not consider the presence of micrometastatic disease in this risk assessment. Could we improve the patient risk stratification with circulating tumor DNA? And we can use it, of course, before any treatment, during treatment, or after treatment. In breast cancer, we face unique challenges for ctDNA detection. We have late relapse after 5 years, 10 years. So how can we detect late relapse after surgery? How long should patients be monitored? In breast cancer, we have very small tumor, 1 centimeter. Breast cancer may have a slow proliferation rate, especially for luminal subtype. And this is a good news for the patient, that we have a high cure rate. So if you want to do an interventional trial, you will need to have a lot of patients on samples. But we also have unique opportunities in breast cancer because we don't prescribe systematic imaging. I mean, CT scan, PET-CT. Imaging is only performed if symptoms are present. So of course, there is a room for improvement here. We have very effective treatment in the metastatic setting. So we can do escalation trial in case of persistent or recurrent ctDNA detection. And we over-treat our patients. So we need to do less treatment in low-risk group. So this is the largest study in the neoadjuvant space with third-generation ctDNA assay. You can see that the ctDNA detection was 91% for triple-negative breast cancer, higher than ER-positive HER2-negative breast cancer, 69. ctDNA detection post-neoadjuvant chemotherapy was a strong prognostic factor. But you can see here in ER-positive HER2-negative, in ctDNA negative group with no pathologic complete response, we still have 25% of relapse. So this is too high. We can't do de-escalation trial here with this assay. The largest trial in the adjuvant space, Monarchy trial, very high risk group of ER-positive HER2-negative breast cancer. In this subcohort, 27% of patients had a relapse. Only 8% of patients were detected at baseline. So baseline MRD positivity was a strong prognostic factor, but the majority of patients with subsequent relapse were MRD negative at inclusion. The dynamic of ctDNA was also a very strong prognostic factor, but still, you can see that 12% of patients who remain ctDNA negative had a relapse. So this is too high. We can do de-escalation based on this. And a lot of patients became ctDNA positive. It means we had in this study a lot of false negative sample. And another study in the adjuvant space, very few stage 1 patients, below than 5%. You can see in the ER-positive HER2 negative group on the right that most patients with a lighter relapse were MRD negative post-surgery. Most patients had several MRD negative samples during the follow-up before the tumor relapse. And the lead time between ctDNA detection and clinical relapse was 10 months here, the median. So this is an ongoing study with Foresight. This is a MSK cohort. This is 50 patients. You can see on the right, we have 60% of ER-positive HER2 negative breast cancer, luminal, 16% of triple negative. And we have a mixed population because we have 22% of stage 1, so low risk group, and we have also high risk group. So we have a mixed population here. We observe that the ctDNA detection before any treatment was 72%, and the pre-treatment ctDNA detection was associated with tumor stage, the tumor size, and the nodal status, not positivity. Tumor subtype was not significant here. Interestingly, patients with negative ctDNA before any treatment, we did not observe any relapse in these patients. So I think with an ultra-sensitive assay, pre-treatment ctDNA negativity may be a key prognostic factor. 4 vignettes. Top left, you can see a patient, 49 years old, triple negative, stage 3. Neoadjuvant treatment, so in breast cancer, generally we do 2 blocks of chemo, 2 different chemo. So first block, AC, you can see a ctDNA level decrease, but no clearance. Second block of chemo, no ctDNA clearance, no clearance after surgery, and a relapse after. Bottom left, you can see a patient, stage 3, HER2 positive breast cancer. First block, AC, ctDNA decrease, but no clearance. Then we introduce HER2 antibodies, and you can observe here a ctDNA clearance before surgery, after surgery, and during the follow-up. And this patient is disease-free. Top right, a patient, ctDNA positive before surgery, MRD negative after surgery. This patient received adjuvant chemotherapy, adjuvant endocrine therapy. Maybe we overtreat this patient, I don't know. On bottom right, you can see a patient, ctDNA positive before surgery, MRD positive after surgery, no clearance by adjuvant chemotherapy, but clearance with endocrine therapy. And you can also observe that most of these samples, the tumor fraction for detection were was close to 10⁻⁶, so 1 ppm. For patients treated with neoadjuvant chemotherapy, you can see here that all post-neoadjuvant samples had ctDNA levels below 10⁻⁴. On 100% of patients with a relapse on available samples before surgery had positive ctDNA post-NAC. 100% of patients with pathologic complete response were ctDNA negative. And in breast cancer, especially in triple negative breast cancer and HER2 positive breast cancer, we use pathologic complete response to escalate or de-escalate treatment. But you can see here that, in fact, we had very few relapse in the non-pathological complete response group. So this is not a good biomarker for escalation. And probably with ctDNA, we can select this patient. Post-surgery, you can see that MRD positivity was very bad, was associated with a bad outcome here, while MRD negativity post-surgery, it's small cohort, but we observed 95% of disease-free. So we can think about treatment de-escalation in this subgroup because 95% is very good. And for patients with positive MRD post-surgery, you can see patients with later ctDNA clearance by adjuvant treatment, they did not relapse, while patients who remain MRD positive, they all relapse. So this is very important also to monitor these patients. So in summary, Foresight CLARITY assay was highly specific and sensitive in this early breast cancer cohort. The clearance of ctDNA can be observed at each phase of therapy and is associated with improved clinical outcome. Post-surgery MRD negativity was associated with a very good outcome. So maybe we can think about de-escalation. Of course, we need more data. And MRD positivity post-surgery was associated with a very bad outcome. So we need to do more. We need to do adjuvant treatment, and we need to monitor these patients to be sure that we have a ctDNA clearance after. So of course, we need more data, and we will present more data in San Antonio.
All right. Well, thank you, Dr. Diehn and Dr. Cabel. So perfect. So before we get into the discussion part of the slides, we at Foresight want to ask really, what can we do with ultrasensitive MRD detection? We think that there's a lot of possible use cases for personalization of therapy at many landmarks throughout treatment. These include, for example, using an early readout of neoadjuvant chemotherapy efficacy using MRD to identify responders or non-responders before they've had their surgery. As MRD becomes more sensitive, this potentially allows us to spare patients surgery and potentially perform organ preservation approaches. Of course, as we talked about quite extensively with Dr. Diehn and Dr. Cabel, we think that there's a big opportunity around looking for MRD post-surgery for deciding who needs or does not need adjuvant treatment. Moreover, we think there's an opportunity even after adjuvant treatment for the possibility of an early readout of clinical trials that are focused on adjuvant therapy, or even selecting patients for escalated adjuvant therapy, escalated adjuvant treatment beyond traditional standard adjuvant chemotherapy. So I really think that the potential use cases for personalizing therapy here are nearly endless. But I'd like to use the last few minutes here to focus on questions that come from the audience. Again, if you can use your the Q&A button on the webinar platform to ask questions. I'm hoping that we can use this moment to go over how we could think about answering these questions and moving this field forward with Dr. Diehn and Dr. Cabel. So with that, I will get us started with a question of my own, which I've heard from multiple other people in other forums, which is I'll first pose it to Dr. Diehn. Is this additional sensitivity really needed? Do we really need to go below 1 part per million? Is parts per million good enough? Do we need to go below 1 part per million? do we need to be even more sensitive than what we currently have? What are your thoughts on when is enough sensitivity enough?
Yes, I think it's an excellent question. I've also been asked that many times. I would posit that sensitivity is enough when we can detect every recurrence immediately after their definitive therapy. So 100% sensitivity for recurrence at an early landmark. And it's clear that the first gen assays that go to about 1 part per 10,000 can't achieve that. At least in lung cancer, what you showed, Dave, is we get about a third of that. Now with the study with the the 2000 phase variant analysis that I showed in that cohort, we got over 2/3 of the sensitivity for recurrence detection at the landmark. So that's a significant improvement. I think a significant enough improvement that makes the assays in the range where they're clinically useful. But of course, we'd like to make it even better. And I think that is, of course, one of the impetuses why you and your team developed the CLARITY platform, which now really leverages phase-seq, but is able to go even further in sensitivity. So I'm a strong believer that the more sensitivity, the better, as long as specificity stays high. And thankfully, specificity with these ultra-sensitive approaches seems to be as good or better than the first gen approaches.
The question here for which I'm going to direct towards Dr. Cabel. I'm going to merge a couple of these questions actually. So there's a question about for breast cancer survivors, can MRD eventually be used for follow-up in place of mammography or other imaging? I'm going to tie this to a question as well as in terms of guidelines inclusions. What do you think? What evidence do we need to move that monitoring forward in guidelines inclusions?
In fact, for breast cancer survivor, mammogram is used for two things: detecting local relapse, that is, maybe we can do with a very ultra-sensitive assay, and with less sensitive assay. In fact, sometimes we had ctDNA positivity, or in fact, it was a local relapse, so yes. But also the mammogram, the goal is to detect second cancer, which won't be possible with a tumor-informed assay. But so I think it's difficult to beat mammogram, and I don't think this is the goal of this type of approach. But yes, we can detect local recurrence, not second cancer. But for me, in the follow-up and in the surveillance of our patient, doing nothing except, do you have any symptoms? This is our consultation. I think, of course, we can do better than this. And as a medical and breast oncologist, I would like to avoid to see sometimes patients in the emergency room because they had a very aggressive, they had a very bad relapse, and I would have liked to detect this before. So,
and as a follow-up to that, Dr. Cabel, what do you think is I share that vision. Where do you think the evidence gaps are to moving MRD forward into guidelines and into being a recommended approach for breast cancer? Where are the gaps and what do we need to do to get there?
I think, of course, if we can show that you have an overall survival benefit, doing this in a randomized trial, it would be the best. So this is one way of doing it, which some teams are doing, but it's not easy to do. I think we should also think about quality of life study, because when we have a relapse, maybe some patients want to know it earlier because some patient doesn't want. But I think quality of life will be really important also, because if we can show that with ctDNA detection, we can avoid to have bone fractures, to have symptoms, to have lack of breath or something like this, I think it will be huge also. So overall survival maybe, but quality of life, it will be really important. And the third thing will be, and I don't know, can we detect more oligometastatic disease with the potential of curation? I don't know. But maybe with detecting earlier, and I hope this, will be able maybe to cure more patients even in the metastatic setting.
So Max has a question here. I think getting along those lines around surveillance versus monitoring. I'll direct this one towards you. Where do you see MRD testing being used clinically? Is this going to be more of a landmark approach? Is that really what we should be focused on? Should it be serial testing? Is it both? and how do we move that forward into the clinic?
Yeah, that is an important question. And I think the answer is really that it's going to depend on the exact clinical setting. It's probably not a one size fits all answer. And also, one has to consider the healthcare economic implications, of course, since one approach is simply more expensive than another. But I think in big picture, the promise of MRD detection, as Luc just mentioned, is that by allowing us to identify the patients with metastatic disease when they have microscopic disease, we open the potential for curing more of those patients, because the systemic therapies we have available in each disease should be more effective when there's less cancer cells and less pre-existing resistance present. So therefore, I think to maximize the chance of that working, we want as long a lead time between detection of MRD and detection of gross, recurrence as possible. And so because of that, I think the landmark approach, if I had to only pick one, it would be the landmark approach, because that would be the earliest you could ever find microscopic disease and should be the longest lead time you'll ever have on gross disease. And what we're seeing, in both the lung data I showed and the breast data Luc showed, we're seeing, up to 2-3 year lead times, maybe even a little bit more, between MRD detection and recurrence in some patients. And so that is a long, long window in which to intervene and when disease is still microscopic. That said, until we get to 100% sensitivity for detection of recurrence, I think there's an argument to be made that the approach that makes the most sense is to do surveillance testing, with the idea being that if a patient is negative, you hold off on adjuvant. And if a patient then converts to positive, be that at the first blood sample or be that 3-6 months later, whatever, that then you would bring in the adjuvant maneuver that's appropriate. That, of course, would need to be tested. But I think, if I had a look in my crystal ball, I think that's where we ultimately will likely end up. But of course, prospective studies will be needed to prove that it works.
Doing clinical trials in all of these settings, right? It's opportunity, right? What we see is opportunity for all these different approaches, and we need to know which one is going to work the best. Reading out those trials takes a long time. So I'm segueing to another question that we have here, which is regarding surrogate endpoints and accelerating those clinical trials and reading out trials faster. I'll start with Luc on this one, but actually would love input from both of you. Is sort of think about using ctDNA potentially to read out a trial for efficacy on adjuvant treatment. Is there an optimal time point? Or what are your thoughts on that?
I think this is crucial because, as you know, in breast, so we have low events. We need to have thousands of patients in phase 3 adjuvant trial. We need to wait 5 years, 10 years. So we have huge new treatments that we want to test. So we need to have an earlier surrogate for sure. And now, as mentioned, some patients already could have ctDNA testing during monitoring. So, some patients, they will be on a phase 3 trial. And in fact, they will do maybe other tests and they will see their ctDNA and say, I want to go out this trial because my ctDNA is not cleared. So I think in breast, it's here because we can do it with less sensitive assay. So we clearly need to define good surrogate of ctDNA, maybe 1 year, 2 years. We can't wait 5 or 10 years anymore in phase 3 trial.
Max, what are your thoughts on surrogacy and time point for the surrogate endpoint readouts, right? Should it be a fixed time point? Is it surveillance? What does surrogacy look like in lung cancer trials?
Yeah, also a great question. And I agree with Luc. I think this is absolutely one of the promises of MRD that could be transformative beyond beyond getting it into routine standard of care, but use it for drug development and for early readout, both early readout in earlier phase studies where you're trying to decide go/no-go decision with a new agent in the adjuvant decision. And you could envision using early MRD clearance as a marker for an effective therapy. And then ultimately, ideally, of course, what everyone wants to do is to use it as an endpoint for at least accelerated approval, if not full approval, in registrational studies. And that will transform how we develop drugs in the adjuvant space and how quickly we can get drugs to the population, effective drugs to the population, and save more people. So I fully believe this is where the field needs to go. As far as the endpoint, That, of course, will likely depend on the disease and the type of treatment being given. There's lots of, in lung cancer, for example, we don't have lots of data in the advanced setting that, you can tell if a patient is going to do well or not, get a benefit or not from immunotherapy after just a single cycle of an infusion, and that's in the advanced setting using ctDNA. So one could envision, doing it after a couple cycles, after 6 months, after 1 year. I think it really depends on the regimen. We have some trials ongoing at Stanford, these are investigator-initiated trials using a first-gen assay where we're using ctDNA clearance as an endpoint, and there we're looking after a couple of cycles, so a couple of months of immunotherapy. So it'll have to be customized. But I think this is a place where absolutely MRD will transform how we bring drugs to our patients. But we're not there. We need to generate more evidence that there's a strong correlation between clearance and cure.
All right, I think we have time for one more question. I'm going to go to the our Q&A for this one as well. But thinking about sensitivity and detecting and the importance, I think there's convincing data that MRD is bad, right? If you have detectable disease, it's a problem. Are we equally good at detecting different locations of MRD? For example, CNS recurrence in lung cancer, or local recurrence in breast cancer. Do we think that this technology, being more sensitive, allows us to detect those locations of disease that may be a little bit more challenging for first generation assays or imaging approaches? Max, I don't know if you have any comments on that from the experience in phase C.
Yes, I see the question about this and from the audience, and particularly about CNS recurrences in lung cancer. And so absolutely, those are harder to detect with first-gen assays. And there's a number of studies have shown that with first-gen MRD assays, that the patients the false negatives, the ones that you miss, are enriched for the CNS recurrences. I don't think we have enough data yet for our approach to know for sure what the answer is. I can say anecdotally in the small cohort I showed, there were only a handful of CNS-only recurrences, but we were able to detect more of those with the phase-seq, 2000 phase variant phase-seq approach than with the SMV-based approach. So it's too small numbers, and I don't have them in front of me to know exactly how much, but I think it suggests that yes, we will be able to detect at least a subset of these difficult to detect recurrences, because it's not that they have no ctDNA. They have less ctDNA than other types of recurrences. And of course, with a more sensitive assay, you're going to be able to detect at least some of those.
All right, great. So with that, I think that we are at the top of the hour. I want to thank our panelists for the excellent presentations, exciting data, as well as our attendees for coming to this webinar. And we look forward to moving this field forward. And I hope everyone has a great week and happy holidays. And we look forward to connecting with you soon. Thanks so much.